A very good afternoon. I'm Aisha. I will be your host for today's webinar. Kindly note that this webinar will be recorded. It is my pleasure to welcome you to our monthly ACTRIS cell therapy lecture series. Today's lecture focuses on gene modification therapies for in utero treatment of hereditary disease. Let's welcome Associate Prof. Chitra Matar, our distinguished speaker for today's webinar. Associate Prof. Chitra Matar is a senior consultant obstetrician and gynecologist at the Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology NUHS, and is also an associate professor at the Yong Lulin School of Medicine NUS. Besides being a research director in her department, she is also a clinical fetal therapist in NUH. As a clinician scientist, Associate Prof. Chitra devotes her research to developing gene modification and stem cell therapies for congenital monogenic diseases that can be applied in utero and perinatally. As a principal investigator in the experimental fetal medicine group in the Department of ONG, Associate Prof. Chitra's work also encompasses improving safety and reducing toxicity associated with in vivo gene addition therapy. Associate Prof. Chitra's other research interests include harvesting the immune modifying and regenerative potential of reproductive stem cell, in silico modeling of congenital cardiac structural anomalies, immunological responses in pregnant women to COVID-19 mRNA vaccines, and promoting good outcomes in high-risk pregnancies. So just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the Q&A function. Prof. Chitra will address these questions after her presentation. And now, without further ado, I will hand the time over to Prof. Chitra. Prof. Chitra, please.
Hi, everybody. It's a real pleasure to be here. Thank you to ACTRIS for inviting me to come on board and give you a brief introduction into gene modification therapies for hereditary disease in the fetus. So I have no disclosures, and I will be presenting some work that may be familiar to you and others that may not be so familiar. So I certainly will entertain and welcome all your questions at the end. So the Earth's population, which currently stands at about 8 billion, is expected to hit about 11 billion by the year 2100. And this brings with it a whole host of environmental challenges, as well as health challenges, because the greatest expansion is predicted to be in developing countries, with most growth coming from African and Asian populations. What does this mean for hereditary genetic diseases? As you can see in this graph in the middle of the screen here, while autosomal dominant and chromosomal disorders remain largely While autosomal dominant and chromosomal disorders remain largely stable, autosomal recessive diseases are predicted to increase in frequency in developing populations in particular. And there are several factors that contribute to this. Certainly the lack of prenatal screening, the lack of prenatal services such as terminations of pregnancy, and perhaps the high frequency of consanguinity contribute to an expected increase in autosomal recessive diseases. These diseases, which are largely single gene disorders, are expected to become a more prominent global health issue. I'm sure this audience is familiar with the damage caused by single gene diseases, and in utero, it is particularly concerning as a lot of these diseases can cause significant fetal damage. It can cause perinatal damage or demise soon after the baby is born. And in surviving babies, there will be developmental obstacles in childhood and adulthood. Any gene therapy that is instituted here after the baby is born and after the disease has certainly caused end organ damage will have limited impact. So therefore, in order to make greater inroads into the treatment of such diseases, we want to step back in time and consider whether or not we can treat the disease in utero while the baby is developing and before significant end organ damage occurs. Single gene defects are a vast spectrum of diseases, most of them infrequent or rare, but together single gene defects can affect 1 in 200 pregnancies. So while postnatal therapy is being trialed, there is a significant amount of benefit, both economical as well as health-wise, that we can gain by considering in utero therapy for the majority of these diseases. So we will go through the concepts and the techniques about which are employed in utero gene therapies. We will cover a couple of clinical disease models, some of which are in clinical trials, some of which have been modeled in utero, and others which have yet to be modeled in utero. So we'll be covering things like primary immunodeficiencies, hemophilia, hemoglobinopathies, especially thalassemia, and neurodegenerative diseases, and some of the new inroads that are being made in gene editing therapies. This audience is familiar with the increasingly sophisticated and accurate sequencing tools for prenatal diagnosis. This can be performed at an increasingly earlier gestation and will certainly aid in advancing the possibilities for fetal therapies. So we will discuss how available technologies have been applied to relevant preclinical animal models, and we will be talking about the data supporting efficacy of in utero gene therapies. So let's talk about techniques first. So the purpose of primary in utero prevention of any kind of disease, particularly a genetic disease, is to effect a single prenatal intervention that will allow for correction of the aberrant genetic function for life. And we can do this by delivering gene therapeutic product either systemically or in a localized manner, depending on the disease profile, depending on which organ is affected and where the devastation occurs, whether it is a multi-organ disease or something that is concentrated in a single system like the central nervous system. Gene therapeutic products can be delivered directly into the organs, or they can be delivered into the bloodstream, into the amniotic fluid, into the trachea, and as long as they can efficaciously target the organ. And there are certain pros and cons of these various routes of approach. Prenatal diagnosis has allowed us to diagnose single gene disorders, and we are working on increasing the efficacy with which we non-invasively diagnose single gene disorders. Currently, the standard of care is to do an invasive procedure such as a chorionic villus sampling or an amniocentesis in either the first or second trimesters of pregnancy to make the diagnosis, and then to sit down with the affected couple and talk about the various options. Practically speaking, there are only two options that we offer affected couples. Either no intervention, we wait and see, we deliver the baby and see if there is any postnatal therapy that can be applied to the baby after birth, or we offer them pregnancy termination. And for people working in this field, it is our sincere hope that we can eventually offer them a third option, which is an intrauterine therapy, either with a stem cell-based therapy or a gene therapy, and both can apply. So I'll briefly talk to you about gene therapy and stem cell-based gene therapies. So in utero gene therapies or gene modification therapies essentially take an engineered DNA and insert it into a delivery vehicle, like a viral vector, for example, or more recently, nanoparticles. And this vehicle will carry the DNA into the affected cell, where the DNA can then be integrated into the host genome, or it can sit outside the host genome in the nucleus, something called an episomal transgene, where it can be read, and where the cell can produce the protein that will enable the cell to correct its aberrant function. Gene editing tools can also be delivered in this manner, and gene editing tools can then either correct the point mutation or correct the abnormal gene to achieve the same effect. So the goal is to create phenotypic improvement via production of the new transgenic proteins by the cells that have been successfully transduced. Now, this gene therapy approach has been successfully used in animal models for a range of diseases, including mucopolysaccharidosis, lipocongenital amaurosis, which is a congenital blindness, glycogen storage disease, hemophilia B, and Crigler-Najjar syndrome, which is one example of an inborn error of metabolism. In utero stem cell therapy, on the other hand, is very similar. It requires the use of genetically normal stem cells, which are transplanted into the fetus in utero and expected to engraft into the organ of protein production, thus taking over the organ's normal protein production, producing the correct amount of the correct protein and leading to phenotypic improvement. So examples would be hematopoietic stem cell transplantation for primary immunodeficiencies or for the major hemoglobinopathies, and mesenchymal stem cell transplantation for osteogenesis imperfecta. Now, why would we want to treat fetuses and not simply wait until the baby is born to treat the disease? Surely waiting for the pregnancy to be over and utilizing fewer invasive procedures would be safer. Well, that may be an argument for delaying therapy until after treatment, but there are many more compelling arguments for actually doing therapy as early as possible. And the main argument is to prevent end organ damage. So as I mentioned earlier, many of these diseases can cause changes in the fetus at a very early stage of the pregnancy. The major thalassemias, for example, Bart's hydrops caused by alpha thalassemia major does lead to in utero demise in mid-gestation or in later gestation. And metabolic disease, such as mucopolysaccharidosis or glycogen storage diseases, can cause sufficient end organ damage such that there is a high risk of perinatal morbidity or severe mortality or severe morbidity. Another advantage is that when you are a very small fetus weighing perhaps 20 grams, you would require a lot less vector or stem cells in order to achieve therapeutic levels of engraftment or transgenic protein expression. So the advantage is certainly the size, which will allow gene therapy to be a lot more effective and cost-effective as well. In addition to the size, in early gestation, particularly less than 18 weeks of gestation, the fetal immune system is not yet ready to react to antigens, and therefore the possibility of inducing central as well as peripheral tolerance to the gene therapy products or the stem cell products is much higher, allowing you to have greater flexibility in retreating the patient at a later and more mature state. You also have access to immune privileged sites, especially the central and peripheral nervous systems. And the main thing with certain diseases such as spinal muscular atrophy is that it's very hard to reach the central nervous system once that barrier closes after a certain level of maturity is achieved. But access to immune privileged sites, including the eye or perhaps even the reproductive system, is actually a lot more efficient in the fetus. We also can rely on large-scale migration of stem cells. So if we were to do a stem cell gene therapy and we needed the stem cell to migrate to the liver or the heart or the lung, or if we wanted to transduce a stem cell and we wanted that stem cell to perform a certain function, this would be physiologically more effective in the fetus. The earlier the stage of the development, the higher the concentration of stem cells and the more plasticity there are in these stem cells. And most importantly, we have improved outcomes with earlier treatment. And this has been shown time and time again in many clinical examples. Younger patients, when treated, have a higher disease-free survival. And you also have the advantage of targeting undamaged target organs, such as the liver or the bone marrow or the brain, which are much more receptive to transduction. Fetal therapy can be performed safely without significantly increasing pregnancy loss. We do fetal therapy for a lot of other things. Nowadays, we're even doing in utero surgery for certain cardiac conditions. So there are many more advantages to treating the fetus than there are arguments against treating the fetus. So we'll talk about how to deliver the gene therapeutic products into the fetus. So there are two approaches: autologous ex vivo gene therapy and direct in vivo gene therapy. if we were to look at direct in vivo gene therapy, the delivery vehicle is directly injected into the recipient, either systemically or locally. So in the fetus, we can do an ultrasound and detect where the umbilical vein is, and we can inject the gene therapy product into the umbilical vein and expect it to be distributed systemically. Whereas if we wanted to target the CNS, we could possibly inject the gene therapy product directly into the intracerebral ventricles. The delivery vehicle is designed to target the specific cell efficiently. So when we inject directly into the fetus, we rely on the efficacy of the gene therapy vehicle to target the cell in question. For example, the liver for hemophilias, neuronal cells for neurodegenerative diseases. Of course, the disadvantage is that non-target cells may also be transduced, and the effect of the transgene can therefore cause unwanted side effects, if unwanted off-target effects, and this may be a clinical problem. But with improving technology, the effect of the transgene may be controlled, and we may even be able to release the effect of the transgene only in the target organ using specific promoters or inhibitors. With the indirect approach, what we are doing here is to remove the stem cells from the fetus, treat the stem cell in vitro, and then put the corrected stem cell back into the fetus. This requires at least a second invasive procedure, and the higher the number of invasive procedures during pregnancy, the higher the risk of miscarriage or intrauterine demise. This, of course, can permanently correct the fetus's own stem cells, and off-target deletions or mutations or insertions can be screened for prior to retransplanting the treated cells. But this also means that there's potentially lower efficacy, and there may be some immune response to the manipulated stem cells, and this may require conditioning, especially if retransplantation is required. I'm so sorry, can I just, sorry for the interruption. I'm not sure what happened there. Let me just reshare the screen. Okay, can you see the screen? I think you can see the screen. Okay.
Thank you.
Thank you. Yeah. Okay, so yes, so these two approaches can be used for both gene editing with gene editing tools or with gene addition tools. And remember, the difference is that with gene editing, we put in a CRISPR-Cas or a base editing system with a guide RNA so that we can correct the genetic mutation in situ. And with gene addition, we're actually delivering a transgene to either be integrated into the host genome or to be expressed episomally. There are plenty of potential adverse effects. For example, loss of expression, especially as the fetus grows, genotoxicity, where the gene therapy product can actually cause unwanted genetic changes in the host genome. Organ toxicity, for example, the viral vectors can cause hepatitis and can cause immune toxic responses, which in certain cases may be life-threatening. And reproductive toxicity, because there is a possibility of these gene therapy products getting into the gametes. So plenty of delivery technologies have been trialed in animal models, as you can see here from this summary. Intravenous, intraamniotic, intratracheal, and intracardiac deliveries are considered to be systemic, as the gene therapy product can get out into the circulation and can hit several organs with one dose, whereas intramuscular, intraperitoneal, or other intra-organ injections are regarded as local or regional. So there are certain disadvantages, such as the lack of specificity, high procedure risk, and variable absorption rates, especially if you put the product into the peritoneal cavity of the fetus or into the amniotic fluid. There is also a potential for bystander effects on adjacent tissues from the transgene or vector, a loss of or dilution of transgene due to rapid cellular division, and silencing due to epigenetic reprogramming. There may also be resistance to gene modification, increased clearance of transduced cells by the immune system, damage to the vector because of changes in pH or temperature, and also transplacental trafficking of the gene therapy vector to the mother, and unwanted or undiagnosed effects in the mother. So these are the potential drawbacks of in utero gene therapy with various delivery routes. So now that we've looked at the technology, let's look at some clinical examples. So we'll start out very briefly with primary immunodeficiencies. I felt that this is an appropriate place because many of the pioneering inroads in gene therapy have been made because of the treatment of primary immunodeficiencies. All right. Okay, so these gene therapy for these conditions have been largely achieved with ex vivo gene therapy. So the patient's own hematopoietic stem cells are removed, manipulated, corrected, often with an integrating lentivirus or retrovirus, and then retransplanted into the patient without immunosuppression because these patients are immune deficient. So while there are certainly many clinical trials for immunodeficiencies that are occurring in infants who are getting younger and younger, the recent clinical trials have actually recruited infants as early as 1 or 2 months old. We still don't have clinical trials for in utero gene therapies. And there are several reasons for this. We know that the fetus is generally safe inside the uterus, and during development, because of the protected environment, there really is no need to treat the fetus until birth. Many newborns with primary immunodeficiencies are born without symptoms until they reach several months of age, because they will still have the protective effect of the mother's antibodies. So therefore, they only become symptomatic a little bit later on. And therefore, the incentive to treat these diseases in utero is perhaps not as strong. But in utero treatment is still an area of consideration because of those advantages that I've spoken about, and certainly clinical trials are being prepared for. But one of the major barriers is that it will still, for the time being, be an ex vivo approach, meaning that we would take the hematopoietic stem cells out of the fetus, correct the gene in the laboratory, and then transplant the cells back again. The reason is because in vivo IUGT is perhaps thought to be a little bit too risky at this point in time, because to treat primary immunodeficiencies, we will need to use integrating vectors, so perhaps a lentiviral vector to permanently integrate the corrected gene into the host genome, and this may cause things like mutagenesis of the host genome that may increase the risk of cancers arising later on in life. This may be undesirable, and it may be one of the barriers against starting in utero gene therapies for this group of diseases. So while clinical trials are ongoing for many postnatal primary immunodeficiencies, in utero gene therapy is still something that we are looking forward to. It has many advantages for the understanding of outcomes of in utero gene therapy, because physiologically non-human primates are very similar to humans. During gestation, they develop at approximately the same rate, and all the procedures that we use to deliver the gene therapy products to the fetus are clinical procedures. So we do ultrasound guided needling of either the umbilical vein or intracerebral ventricles or the peritoneal cavity in order to deliver our gene therapy vehicles where we want them to go. And in early and late gestation, the non-human primate model also displays differences in immune maturity that would be important to understand if we were to treat genetic diseases in humans. The duration of expression of the gene therapy product is an important step in advancing any kind of gene therapies, because ideally we'd want one hit, one kill kind of outcome, where we just give one dose and that gives you the therapeutic effect for life. So because non-human primate pregnancies are quite long, we can actually look at different stages of the pregnancy and track the gene therapeutic product expression. So in short, very similar to how we would perform clinical surveillance for beneficial as well as toxic outcomes. So here in this model of hemophilia B, we have used adeno-associated viral vectors, which are in many clinical trials in diseases ranging from rare monogenic diseases to cancers and infectious diseases. And adeno-associated viral vectors, or AAVs, are numerous. They actually are considered to be non-pathogenic because we have been exposed to many throughout our lifetime, and they can be easily modeled to target different organs. So capsid proteins can be changed to produce pseudotypes, which can then target different organs with increased efficacy. So we use pseudotypes AV8 and AV5, which are liver tropic. They target hepatocytes very well. And we have published a number of papers describing short and long-term outcomes in the non-human primate. So briefly, how we conducted our experiments was, as I mentioned to you earlier, very similar to what we would do in the clinics. So we have time-mated non-human primates. We scan them to date their pregnancies, and we decide when we're going to inject the gene therapeutic vector, either in early gestation, which is about 0.4 gestation, 0.4 G, or at later gestation, which is about 0.9 G. And this is important because you have the pre-immune period below the approximate midpoint of the gestation, and the post-immune period where the immune system is more mature and is expected to respond to foreign antigens. We administer the gene therapeutic product systemically, so that's either intravascularly if we target the intrahepatic vein, or via the peritoneal cavity. And then we do serial blood monitoring, serial fetal blood sampling in utero, and serial blood sampling and organ biopsies postnatally in order to determine transduction efficacy, transgenic protein expression, as well as any unwanted effects that will be important for assessing biosafety, toxicity, and tolerance. So what we found was that gene therapeutic efficacy is related to the serotype. So in our animals, AV8 outperformed AV5, and it's also related to the gestational age. So again, in our animals, the later gestation recipients had a much higher therapeutic efficacy of transgene expression compared to the early IUGT animals. We also switched up the transgene. So here we are replacing here we are replacing factor 9, and we switched out the transgene for factor 10. And we found that both transgenes were equally effectively expressed. The additional factors influencing transgene expression would be the stage of rapid early infant. So you see here how infants gain weight very rapidly postnatally, but we still see a maintained level of transgene expression, suggesting that at least during this period of monitoring, the transgene expression is not lost through a dilutional effect, which is important to consider because this is one of the problems with postnatal therapy, either in a young infant or in an adult, where as the recipient grows and the cells divide, we see an eventual loss of the gene therapy transgene expression. We also find that gender or sex is a determinant of expression efficacy because males in our cohort outperformed females. And this may be due to hormonal influences, or it may be due to X-expressed proteins. We haven't investigated this further. As I mentioned before, serotypes are important. So the serotype used will determine how effective the transgene is, but that also gives us some flexibility. So if a recipient has some natural immunity towards AV8, at least we know that there is another serotype that can potentially circumvent this natural immunity, and we can still consider producing a gene therapy product based on an alternate serotype. So we talked about gender and gestation. Certainly these do have, do show either a tendency to improve performance or a tendency to inhibit performance. And we are able to assess both humoral and cellular immune responses. As we know, at 0.4 gestation, the fetal recipient is immunologically less mature, but these earlier fetuses still are able to mount humoral and cellular immune responses. So while most animals maintained expression, some animals actually lost expression, and this occurred at the same time as the development of neutralizing antibodies. So it's not true what people think about the fetus being immune naive. Fetuses aren't exactly immune naive. They have the ability to form immune responses and even form neutralizing antibodies towards the gene therapy vector. So this is something that is important to consider when we are conducting a gene therapy trial and when we are looking at short-term and long-term outcomes. So the humoral response has been responsible for the loss of transgene expression with AAV-mediated gene therapies. Humoral response such as anti-capsid antibodies, neutralizing antibodies, and anti-transgene antibodies. So we saw in our animals that both fetuses treated in late gestation as well as early gestation were able to form anti-capsid antibodies with a higher response coming from the older animals as expected. Cellular responses were also conducted, and small numbers of our treated animals were able to mount cytokine and T-cell mediated responses to the initial product, as well as to the same vector product when we gave it to them again in the postnatal period. So this tells you that even if we treat fetuses early in gestation, there may be immune-mediated loss of efficacy or immune-mediated adverse outcomes that we need to be aware of. There are also other effects, for example, hepatic effects. Now, in postnatal trials in young adults and in older adults, men with hemophilia B who have been treated with this AAV8 clinical vector have developed hepatitis. And because the inflammation wipes away the transduced cells, we often expect a drop in the transgene expression once hepatitis occurs. And therefore, these patients need to be treated with steroids in order to maintain transgene expression. We didn't see very much in the way of transaminitis or hepatitis in our treated animals. There were one or two that developed transient increases in ALT, but by and large, there was no clinical transaminitis that we noted. And another concern is, of course, whether or not the vector integrates. So AAV is popular because it is considered a non-integrating vector. So it stays outside of the genome in the nucleus and is expressed without having to integrate into the host genome. However, we discovered that AAV actually does integrate into the host genome in very small amounts. So we can see that through deep sequencing, that the integration of AAV is related to the vector copy per cell. So if we give a higher dose of the gene therapy vector, we expect more vector copies per cell, and that increases the risk of integration. And we did actually show that vector integration occurred at very small amounts in recipients who received AAV at both late stage and early stage of pregnancy. But reassuringly, these integrations did not occur in oncogenes or did not disrupt tumor suppressive genes. So in a sense, the data is reassuring that even though it does occur, the risk of long-term mutagenic effects may be quite rare. But certainly something to bear in mind as we know that we need to perform lifetime surveillance for side effects in gene therapy recipients. Germline transmission is also a possibility. We know that we saw from our own animals that there was a very low transmission rate of the AAV to oocytes and of treated females. It was a bit harder to prove this in treated males, But because this can happen, there is potential for germline toxicity that we need to be aware of. And maternal bystander effects can certainly be a clinical problem, because we know that vectors are small enough to traffic across the placenta. So we showed in our dams our mothers whose fetuses were treated in utero that there was some immunological reaction to the small amounts of vector that crossed over the placenta. And though these did not cause any clinical symptoms, maternal bystander effects are an important category to consider for IUGT. Okay, so now we move swiftly on to another model, and that is thalassemia. So the major hemoglobinopathies, alpha and beta thalassemias in particular, are a significant global problem. They're the most common monogenic condition globally, and in Southeast Asia, about 11% of the population are beta thalassemia carriers, and about 40% of the population are alpha thalassemia carriers. There are approximately up to 500,000 severely affected children born annually in the world. So it is, a problem that requires an urgent solution, because, as you are aware, the failure of alpha or beta globin genes can either cause in utero demise or would require the subject to be treated with blood transfusions until he or she can receive a bone marrow transplant, which, as we know, is perhaps only available to 25 to 30% of needy recipients. So most other treatments are palliative and not curative. Currently, with prenatal screening, we can offer couples counseling, and we can offer the termination of pregnancy or to have the baby, and to treat with either a stem cell transplant or to treat with blood transfusions. But as this audience knows, there are certainly complications that are associated with transplant or with blood transfusions and iron chelation. Now, many animal models have studied in utero hematopoietic stem cell transplantation, but this is complex and challenging because there are significant engraftment barriers. There is there is the immune tolerance or the immune barrier with prenatal transplantation. Postnatal transplantation requires bone marrow conditioning to free up the niches to allow engraftment of donor cells. In very early gestation, transplantation can be effective, but in very early gestation, it may be quite hard to make the diagnosis and to arrange for treatment to meet that very narrow window of opportunity. And in later gestations, and certainly postnatally, you need quite a high donor cell dose to overcome competition from host cells and to engraft efficaciously at the therapeutic levels. And also, the availability of donor cells and the interaction of donor cells with the host immune system is something that has inhibited the progression of in utero stem cell transplantation into clinical application. So because stem cell transplantation is not very effective, then people have certainly been studying gene therapy for decades. This is an example of fetal gene therapy of alpha thalassemia in a mouse model where a lentivirus carrying the alpha globin gene was used and injected into the vitelline veins, and led to an increased expression of red blood cells and improvement in other hematological markers, although this did not rescue terminally affected fetuses with alpha thalassemia major. Our group has done the same approach for beta thalassemia major, where we used a lentiviral vector expressing the human beta globin gene and injected this into a mouse model of severe beta thalassemia intermedia, where the affected pups have a shortened lifespan and they are very obviously thalassemic, as you can see here. And what this did was to improve the hematological indices, including hemoglobin, MCV, and RDW, and improve microcytosis, as well as improve hepatosplenomegaly. And this was more effective than the same mice being treated with genetically normal hemopoietic stem cells. So gene therapy is the more effective treatment option, but because gene therapy in this case requires an integrating viral vector so that the hemopoietic stem cells can successfully produce the correct beta or alpha globin gene for the duration of the subject's life, we are going to have problems with integration and so on. So this is something that has still not made it into the clinics, but perhaps in utero nanoparticle delivery for genome editing may make it into clinics sooner. So this is a paper by a group led by Mark Saltzman, where they showed that they can safely deliver polymeric nanoparticles to a fetal mouse, targeting the hemopoietic tissues at different gestational ages. Safely administered these nanoparticles either intravenously or via the intraamniotic route, with no adverse effect on survival postnatal growth. These nanoparticles carry the donor DNAs and genetically correct the pathological beta globin mutation. A single in utero dose was shown to successfully elevate hemoglobin and reverse significant anemia, reverse splenomegaly, improve survival of treated pups with no detected off-target mutations. So certainly nanoparticles will be an exciting field to watch if we can improve the efficacy of organ targeting. So we move on to neurodegenerative diseases. And fetal gene therapy for neurodegenerative diseases is important because many of these inborn errors of metabolism that give rise to CNS effects start very, very early on in the pregnancy and oftentimes cause irreversible brain damage by the time the baby is born. Again, going back to AVs, AV9 has proven very effective at targeting neuronal cells, and these could be neuronal cells, astrocytes, microglia, and so on. So this is the paper that we published in the non-human primate showing how effective AV9 targeted the CNS and the PNS. And certainly Zolgensma is AV9 carrying the SMN transgene used to treat spinal muscular atrophy. So with the AV9 gene, with the AV9 transgene expressing glucocerebrosidase, we treated a mouse model of Gaucher disease. Gaucher disease is a pretty devastating neuropathic disease. There is a spectrum of phenotypes, but there is a perinatally lethal entity that can be targeted with in utero gene therapy. We delivered AV9 directly into the brain by injecting it into the intracerebral ventricles in a mouse and in a monkey model. The mouse disease model showed distinct improvement in histological and structural improvement affecting the microglia, the astrocytes, and the lysosomal compartment of the brain, and clinically improved the phenotype of affected mice. In utero treatment was much more effective than neonatal treatment, and treated mice lived for up to at least 18 weeks, whereas untreated mice died almost immediately after birth. Treated mice were also fertile and fully mobile, and neurodegeneration was pretty much abolished. So this shows that it is possible to treat a potentially devastating disease in utero with the correct gene therapeutic vehicle. Another important neurodegenerative disease would be spinal muscular atrophy. And this is important because it isn't common, but it can affect about 10 in 100,000 newborns. And it's life-threatening with significant neurodegeneration related to deletion or mutation of the survival motor neuron or SMN gene. A group in Taiwan and in London showed that the in utero transplantation of human amniotic fluid stem cells, which can differentiate into various different cells, including hemopoietic cells, rescued an SMA mouse model, which was created by knocking out the SMN gene. and transplanted fetuses showed better performance on all motor function tests and significantly higher frequency of neuronal cells and myocytes. This, first of all, leads us to see that it is possible to treat SMA in utero. And then more recently, a group showed that with gene therapy using a single injection of AV9, this can rescue an SMA mouse. So intracerebroventricular injections of AV9, the same technique that we use in the Gaucher's model, led to extensive expression in different parts of the CNS with a great number of transduced neural stem cells, showing us that with a single injection, we can get very substantial improvement in clinical outcomes, of course, and with the AV9 being delivered directly into the brain, there's possibly less risk of spillage into the vascular system and less distant target organ effects. So this may be the safer approach for SMA if we want to target it utero. So we'll move on to osteogenesis imperfecta, and this is a dominant negative mutation in which point mutations give rise to abnormal collagen. We've treated osteogenesis imperfecta in utero using mesenchymal stem cells that were derived from terminated fetuses. And these mesenchymal stem cells, although they did not engraft at detectable rates, they did allow the significant clinical improvement in the sense that these fetuses that had already developed fractures in utero had a reduced number of fractures postnatally, grew at a normal growth rate postnatally, and did not appear to have any long-term or distant organ adverse outcomes. So because stem cell therapies may be a little bit more difficult to implement in terms of regulation or in terms of stem cell supply, gene therapy is still very much an option here, and novel genetic therapies are still required to deal with the genetic cause. So a lot of work has gone into silencing the gene expression of abnormal collagen, therefore converting severe OI into mild disease. And people have also looked at antisense RNA or DNA molecules, which are complementary to the mRNA for the mutant protein in order to bind the target mRNA and prevent its translation. So this is still a space in which we need to watch the progress of gene therapy. Gene therapy is being developed. And lung and metabolic disease have in recent years also been potential targets for an in utero approach. So the group led by Bill Parenteau have used in utero gene editing successfully to model monogenic lung disease. Monogenic lung diseases include inherited surfactant protein syndromes and things like cystic fibrosis, which can cause early damage either isolated to the lung or affecting other organs as well. And they used a CRISPR-Cas9 gene editing approach packaged in an adenoviral vector to deliver the gene therapy vehicle via the intraamniotic route, so delivering the vector into the amniotic sac. And because the lung is bathed in amniotic fluid, we can see very healthy transduction of the lungs and high efficacy of transduction of pulmonary epithelial cells. So they used it as proof of concept in a mouse model of human SFTP-C173T mutation, which causes severe diffuse parenchymal lung disease and rapid demise of mutant mice at birth. And they showed that treated fetuses and neonatal mice showed improved lung morphology and lung histology with increased survival. So that's certainly very exciting in the development for lung diseases, including cystic fibrosis. They also used CRISPR-Cas gene editing to treat a model of hereditary tyrosinemia type 1 in a knockout mouse, again packaging the CRISPR-Cas9 system into an adenoviral vector and delivering this directly into the liver of the fetal mice. They showed that there was long-term persistence postnatally of edited cells in this mouse model, as well as a rescue of the lethal phenotype of HT1 following in utero targeting. So this is a possibility. This is a new possibility for monogenic disorders, especially if a gene addition therapy is undesirable or it has potential, adverse effects such as integration. This can be expanded to other liver diseases or other diseases where the liver produces the necessary proteins like hemophilia. So this is, an exciting development showing that gene editing can also successfully target monogenic diseases in utero. So when we talk about in utero gene therapies, we have to think about the potential ethics and controversies. So we know that there are plenty of advantages, but also there may be potential disadvantages. And one of the considerations is whether or not the fetus should be potentially compromised in order to achieve a therapeutic effect, and whether the mother should be put at risk in order to achieve this potentially therapeutic effect. Another interesting area to think about is taking it one step further and considering whether or not we can treat this disease in the embryo in vitro. Because if we can treat it in the fetus, why don't we think about treating it in the embryo and circumventing or bypassing potential maternal bystander effects? So now embryo gene editing is in the news, of course, recently because of recent controversies and whether or not we should pursue embryo gene editing. But with the increasing availability of prenatal diagnosis and even pre-implantation genetic testing, embryo gene editing or embryo gene modification becomes a possibility. So we need to compare from the clinical sense, what the potential side effects are of treating the embryo versus treatment in the fetus and neonatal treatment. And we need to think also about what the potential controversies are, the ethical considerations of treating either diseases in either the embryo or the fetus. So this is something that we need to develop as we develop our technological prowess to treat these diseases at a much, much earlier stage of development. So I'll leave you with the last slide. We know from the last 40 years or so that fetal therapy can certainly be effective, although it hasn't made that cross from laboratory animal to clinics just yet, more because of the fear of the unknown, the fear of long-term side effects. We know, especially from the last few years of research, that primary gene therapy in utero is effective and more effective than stem cell therapy. And we can model the gene therapy delivery vehicle to increase the therapeutic effects, to target the desired organs so that we minimize side effects. And we know that there are certain biological factors that can affect the long-term outcomes. We also need to bear in mind that toxicity issues probably haven't been sufficiently addressed. These need to be addressed in long-term models because it will take time for these side effects to turn up, especially if we're thinking about outcomes related to germline transmission or genome integration, very low likelihood of malignant change, but we can't enumerate that right now. And the future reproductive health of the recipient, as well as maternal bystander effects. So in conclusion, we can individualize treatment and tailor-make strategies to improve the efficacy and outcomes of gene therapy. Overall, especially in large animal models, gene therapy outcomes has been encouraging, and we just need to be brave and take the next step into clinical trials for IUGT. So I'm really sorry about running over time, and thank you for your patience as I sorted out the technical problems. These are all the wonderful people that I have had the pleasure to work with over the last 10 years or so. And if there are any questions, I'll be very happy to take them. Thanks very much.
Thank you, Prof. Chitra, for the very detailed presentation on your work. So as of now, it looks like we do not have any questions. If anyone has any questions, please feel free to type your questions in the Q&A function below. Prof. Chitra, would you like to share some interesting facts to wrap up your presentation?
Well, okay, so we have spent the last, I would say, 10 to 12 years concentrating on in utero stem cell transplantation, because the general consensus in the field is that stem cell transplantation is safer because we're using unmodified genetically normal stem cells. And it's very similar to in utero blood transfusion in terms of the technical aspects. But we have unfortunately also produced more convincing data that it's really not very effective, especially in the diseases that we want to treat, like alpha and beta thalassemia major. So now the field is shifting back to gene therapy. So whereas once gene therapy was considered something that will probably never be performed in utero, I think the opinion is turning, and I do believe that we will soon see in utero trials being done, especially for something like immunodeficiencies or SMA. But time will tell, and hopefully Singapore and our institutions will be right up in front of this very exciting development.
So thank you so much, Prof. Chitra, for the wonderful presentation. I'm sure our audience has gained a lot of knowledge from your very detailed presentation. So we have now come to the end of our lecture. On behalf of ACTRIS, we would like to thank you for your time today, and we hope to see you again in our to everyone here, our audience, we hope to see you again in our next lecture on 23rd of May. So as a sign off, you will be asked to answer short survey questions regarding the webinar. We appreciate your feedback as it helps us to be better at what we do. So once again, thank you, Dr. Chitra, and thank you, everyone. Have a good afternoon.
Thank you. Thanks a lot. Bye-bye.